Good afternoon to all. My name is Dr. Danielle LaRoccarina, and I would like to welcome you to the Women in Medicine Legacy Foundation's presentation of the 2023 Alma de Morani MD Renaissance Woman Award. I want to thank Dr. Eileen Fenoy and Dr. Connie Newman for their leadership as chairs of the selection committee of the Alma de Morani Committee and the entire board of directors without whom and the staff without whom we could not do this. During the entirety of the event, and especially during the Q&A, if you have any questions or comments, please use the chat function at the bottom of your screen. The support staff and I will present questions to our awardee, but be aware that, given time constraints, your question might not be answered. The event is being recorded and will be posted online in the coming days. And now it's with a special treat. Please join me in welcoming our co-host, the New York Academy of Medicine and President, Dr. Ann Kurth.
Thank you, President LaRoccarina. Good afternoon and welcome, everybody. I'm Dr. Ann Kurth, President of the New York Academy of Medicine. Before we get started today, I'd like to take a moment to acknowledge the Women in Medicine Legacy Foundation on celebrating their 25th anniversary. Please join me in congratulating them on this tremendous milestone. For all the work that you have done and all the work they will continue to do, here's to the next 25 plus years. And now, on behalf of NIAM and the Women in Medicine Legacy Foundation, welcome to the 2023 Alma de Morani Award presentation. We're delighted to continue our outstanding partnership with the Women in Medicine Legacy Foundation and for NIAM to be the home for this very special event. It's exciting to partner with another like-minded organization that also recognizes and celebrates the invaluable contributions of women in medicine and our shared roles towards building health equity. The New York Academy of Medicine is a leading voice for innovation in public health. In a world where there are increasing health disparities, compounded by the pressures of climate change, NIAM's work is focused on partnering to innovate for the health of New York City, the nation, and the planet. Today, our work addresses challenges to health across the lifespan, from safe birth to healthy aging. We want everyone to have the opportunity to live more healthily and to be well, to have the longest possible health span, leveraging science to do so. And so that's why it's so exciting today that what we're doing here is recognizing that individual clinical science excellence and building upon the historical contributions of generations of women in medicine. Today, we're recognizing an inordinately accomplished woman, Dr. Nanette Wenger. Over the long course of her incredible career, Dr. Wenger became one of the first physicians to focus on heart disease in women, since this disease was initially presumed to primarily affect men. Her groundbreaking research has led to the advancement of knowledge and practice of women's heart health, cardiovascular disease prevention, cardiac rehab, and geriatric cardiology. From the commendations you will hear today, it's going to be extremely clear why she is being presented with the Alma de Morani Award. Once again, thank you all for joining us today. I'd like to welcome back Dr. Danielle LaRoccarina, who is a senior research scientist at NIAM and president of the Women in Medicine Legacy Foundation. It was through her foresight that our two organizations came together for this collaboration. Thank you, Danielle.
Thank you, and Dr. Kurth. It's such a pleasure to work with you. And thank you to the New York Academy of Medicine for partnering with us, not only for this presentation of the Alma de Morani Renaissance Women Award, but for all the cooperative programs between the Women in Medicine Legacy Foundation and NIAM that promote the history of women in medicine now and in the future. This partnership is in its 5th year, has already been tremendously synergistic to the mission of our foundation. And we are also thrilled to be working with the Academy. The Women in Medicine Legacy Foundation, just to give you a little bit of history, was founded 25 years ago with a strong belief that understanding our history plays a powerful role in shaping our future. The resolute stand women took to establish their place in medical fields propels our vision forward. We serve as stewards to stories from the past and take pride in sharing them with the women of today. For 25 years, the foundation has made significant accomplishments in promoting and advancing the history of women in medicine and the medical sciences, and in public health, I might say, through our annual Renaissance Woman Award, research fellowships, oral history collection, processing of grants, and scholarship programs. Recently, we completed a pilot initiative called the Hub. I love that name, which begins to catalog and electronically display biographical and professional materials from a diverse array of illustrious women in medicine, making the legacies of women in medicine visible and discoverable. The Hub draws from the discipline of history to engage researchers, educators, and the medical community in conversation, learning, reflection, and knowledge production related to the experiences of women in medicine, science, and public health. Now, obviously, there's always the challenge. We need your support. None of this would be possible without the support of private donations from you, who share our passion to preserve and promote the history of women in medicine and the medical sciences to impact medicine in the future. Your gifts help support our programs and in large way enable us to promote our mission nationwide, actually in North America, which is where we extend our reach. I encourage you to become a member of the 1849 Society and join us in our efforts to advance the role of women in medicine today. To our supporters to that end, let me thank today's event sponsors, including myself and my husband, Dr. Luigi Arena, Dr. Connie Newman, Dr. Christy Huddleston, and Rafael Parada Doria. It's a pleasure to have their support. And finally, the foundation created the Alma de Morani Renaissance Woman Award to honor outstanding contemporary woman physician or scientist in North America who has had significant impact on our knowledge and understanding of medicine and medical science, while also contributing, of course, to humanitarian causes, social sciences, or the arts. Recipients demonstrate professional excellence, a thirst for knowledge, and service beyond their medical practice or scientific endeavors. It was named for Alma de Morani, the first woman admitted to the American Society of Plastic and Reconstructive Surgeons and an advocate for humanism in medicine. Alma de Morani was drawn to medicine by the Women's Medical College of Pennsylvania, graduating in 1931. Her love of art drew her to plastic surgery, and she set the standard for the Renaissance woman. Her father, Salvatore Morani, was a famous sculptor, and during his lifetime, he cast the hands of famous surgeons. Among this collection was the cast of a famous woman who had a hand surgeon, his daughter, Alma. So most appropriately, the Renaissance Award is a copy of the hand of Alma de Morani, the namesake of this honor, and one who epitomizes the meaning of the award, created by another Renaissance woman, artist-physician, Dr. Wilma Balkan-Siegel. Thank you so much, Wilma. You have been such a contributor to this organization. To introduce our esteemed awardee, I would like to introduce you to Dr. Ellen Gritz, who herself received the Alma de Morani Award in 2008. Dr. Ellen Gritz is Emerita Professor and former Chair of the Department of Behavioral Science at the University of Texas Anderson Cancer Center and held the Ola Stribling Distinguished Chair for Cancer Research during her career. Dr. Gritz is an established leader in cancer prevention and control research and an internationally known investigator. She has published extensively on cigarette smoking behavior, including prevention, cessation, pharmacologic mechanisms, effects on weight, and special issues of concern to women in high-risk groups, including ethnic minorities, youth, cancer patients, and persons living with HIV/AIDS. Her work has also included skin cancer prevention, psychological aspects of genetic testing, and counseling for hereditary cancers, and quality of life in cancer patients, survivors, and their families.
Thank you so much for the honor of introducing our 2023 Alma de Morani awardee. One of the pleasures of being an Alma Morani awardee myself is the opportunity to interact with other awardees. Some we have known for years, and others are women leaders who we are meeting for the first time. All those women have made extraordinary contributions to the medical and health sciences. Today, I am delighted to introduce Dr. Nanette K. Wenger. Dr. Wenger is professor of medicine in the Division of Cardiology at the Emory University School of Medicine. She is also a consultant to the Emory Heart and Vascular Center and a founding consultant at the Emory Women's Heart Center. In a legendary career that spans more than 50 years, Dr. Wenger's steadfast dedication to reducing women's disability and death from cardiovascular disease has made her one of the country's most respected experts on coronary heart disease in women. A trailblazer and pioneer, she was one of the first female graduates of the Harvard Medical School and the first female chief resident of cardiology at Mount Sinai Hospital in New York. She has received a multitude of accolades and awards through her career, including the American College of Cardiology Lifetime Achievement Award 2022, the Lifetime Achievement Award from the World Heart Federation in 2022, and the Gold Heart Award, the highest award of the American Heart Association in 2004. 2 awards have been named in her honor: the annual Nanette K. Wenger Distinguished Lecture focusing on cardiovascular prevention in women from the American Society of Preventive Cardiology, and the annual Nanette K. Wenger Award for the best scientific publication in cardiovascular disease in women by the American Heart Association. Most recently, the Emory University School of Medicine established the Dr. Nanette K. Wenger Distinguished Professorship for Women's Heart Health Research in 2022. Now, historically, heart disease was thought of as a man's disease. Today, thanks to the pioneering clinical and research efforts of Dr. Wenger, it is known that cardiovascular disease is the #1 killer of women in the United States, accounting for 38% of all female deaths, including more mortality than all forms of cancer combined, which is something I thought I would never see having had a career in oncology. One of the main reasons for the disparity is heart disease symptoms can present differently in women than in men. Dr. Wenger helped write the 2007 guidelines for preventing cardiovascular disease in women. In fact, Dr. Wenger has authored or co-authored over 1,700 scientific and review articles and book chapters, and continues to serve on the editorial boards of numerous professional journals. She is a sought-after lecturer for issues related to heart disease in women, heart disease in the elderly, cardiac rehabilitation, coronary prevention, and contemporary cardiac care. On a more personal note, Dr. Wenger was an accomplished ballet dancer up until medical school and has maintained a vibrant community leadership and advisory role in multiple organizations, including Hadassah and the Atlantic Symphony, among others. She is truly a cornerstone of her community. For these and many other reasons, we honor her today. I am delighted to present to you the 2023 Alma Morani awardee, Dr. Nanette K. Wenger.
So very, very much. I am both honored and humbled by this award, and would like to share with you a comment of one of my colleagues about my career. She said she was reminded of it by a quote from Ralph Waldo Emerson. And Emerson said, "Do not go where the path may lead. Go instead where there is no path and leave a trail." I think I've left that trail. And with that trail, I'd like to accept this award in honor of the numerous clinicians and scientists who followed that trail and over the years have turned it into a huge information highway about heart disease in women. I salute each one of them, as well as the young clinicians and scientists who will continue this very important work. Now, let me start my presentation, if I may have the first slide, please, which I've called Cardiovascular Disease in Women. And what I will do is address the epidemiology, awareness, access, and delivery of equitable health care. The next slide shows my disclosures. And next, please. Let me start for each of these areas, providing you with some background information and then highlighting the knowledge gaps. The background, which you've heard, is that cardiovascular disease remains the leading cause of mortality among US both women and men. And over the years, research has identified very important biologic differences between women and men and the way they respond to social, environmental, and behavioral stresses. But sadly, the underrepresentation of women in all aspects of biologic research delayed the translation of these discoveries to women. If you take but one message away from my presentation, I want it to be this: we need a cultural shift in the way we present cardiovascular health data, both to health professionals and to the public, because we identify the characteristics in men as the implicit gold standard, and the presentations in women are termed atypical. Fact of the matter is, they are typical for half of the world's population. But importantly, as we will explore, the pervasive gaps in knowledge and care delivery for women require urgent attention if we are to reduce sex-based disparities and achieve equity in health care. Next, please. Now, traditional cardiovascular risk factors are highly prevalent in women in this country, but there are very important racial and ethnic differences. Let me give you a few examples. Hypertension is highest in non-Hispanic Black women. LDL cholesterol, highest in non-Hispanic white women. Diabetes, most prominent among Hispanic women. And let me comment that when I use the term Hispanic in my presentation, this cohort is mostly Mexican American, because that is the population from which these data were derived. Overweight and obesity, highest in non-Hispanic Black and Hispanic women. Now, the prevalence of the traditional cardiovascular risk factors is similar for both genders, but sadly, the control of hypertension and diabetes and dyslipidemia is suboptimal both for women and for men. But what we must emphasize, both to health professionals and to the public, is that smoking and an elevation in systolic blood pressure are the first and second risk factors that account for years of life lost. Important because they are eminently reversible. Next slide, please. Now, we all know about the traditional cardiovascular risk factors, but what has not been highlighted, and what I will try to do today, are sex-specific risk factors for women. Early menarche before 11 years of age, premature menopause before age 40, polycystic ovarian syndrome, hypothalamic amenorrhea, and then a number of pregnancy-related issues. Hypertensive disorders of pregnancy, including preeclampsia, gestational diabetes. Preterm delivery puts a woman at increased risk. If she has a low or high birth weight fetus, uses oral contraceptives or menopausal hormone therapy. And what we see that is very important for our public health is that when there is low cardiovascular health in pregestational and pregnant women, it increases the likelihood that they will have adverse pregnancy outcomes, and maternal mortality is a tragedy in these United States, but it also decreases the cardiovascular health in their children. so it goes on to the next generation. Next. And then in addition to the sex-specific risk factors, there's sex-predominant risk factors. So if there's systemic inflammation or autoimmune disorders, lupus, rheumatoid arthritis, this imparts cardiovascular risk. For example, the woman with lupus will not die of her lupus. She will die of the cardiovascular complications. Depression and anxiety more frequent in women, especially at younger ages. And then obviously the chemotherapies for cancer, especially breast cancer. The tragedy is when I see a woman in my clinic and I say, congratulations, you survived your breast cancer. But now as a complication of that therapy, you now have heart failure. And this is an area we must address. And then because this is a public health problem, we must examine population attributable risk factors, because this is a metric that we need if we are going to prioritize our public health interventions. For example, among white women, obesity and hypertension is their highest risk factor for the development of heart failure. In Black women, what we've seen is a temporal increase in the occurrence of diabetes as a risk factor for heart failure, probably related to sedentary lifestyle and obesity in part. In Black women, hypertension and diabetes give them the greatest risk for the development of heart failure. Next. And what I want to do is just to give you some idea of spectrum of what cardiovascular disease in women involves and why we have concern. Nearly half of all women in this country have cardiovascular disease if we include hypertension as a cardiovascular disease, which it is. But there's a higher prevalence of coronary disease and heart failure and stroke in non-Hispanic Black women. They are unduly burdened. Women are different. We have more ischemia without obstructive coronary disease and more myocardial infarction without obstructive disease of our epicardial coronary arteries. Women have more spontaneous coronary artery dissection, a newly recognized problem. And even though the prevalence of stroke is comparable for both women and men, women have greater mortality and disability, and we'll come back to that in a few moments. We always used to think of peripheral arterial disease as a problem of men. Fact of the matter is, it's more common for women who have significant morbidity and mortality, and despite this, are left often treated with evidence-based therapies. And the sad part in these United States is in the past 4 decades, the deceleration that we've seen in cardiovascular mortality has slowed, sort of the leading edges of an impending storm, and we're seeing an increased mortality from heart failure. Next. Now, as clinicians, we use quantitative risk assessment tools, and those risk assessment tools, very well established, include age, sex, race, total cholesterol, LDL cholesterol, systolic blood pressure, antihypertensive therapy, a history of diabetes, and smoking. We use these risk assessment in making a decision who needs primary prevention of coronary disease. I use it day in and day out in evaluating the risk for non-cardiac surgery. But what is the applicability of these risk scores to diverse racial and ethnic groups? The data were derived predominantly from middle-aged Caucasian men. Social determinants of health, so important, are not captured by these risk assessment tools, nor are what I've just discussed with you, the pregnancy-related factors and chronic inflammatory disease. And I think an issue particularly germane to women is that in our practice guidelines, what I've outlined above are identified as risk enhancers, which suggests that these matter less, but they must be more important for women than just risk enhancers, and particularly young women. So that what we have is a need to integrate women's specific risk factors in the scores that we use day in and day out in our clinical practice. Next. Now, Important for us to emphasize is the importance of a healthy lifestyle, because the preventive interventions are grounded in this healthy lifestyle. We all knew this over the years as the American Heart Association's Life Simple 7. Now it's changed. We've added one more. It's now Life's Essential 8. And in addition to the ones that I will go over with in a moment, it includes healthy sleep. But we're talking about non-smoking, control of weight, physical activity at goal levels, a diet consistent with guideline recommendations, an untreated total cholesterol below 200, an untreated blood pressure below 120/80, and fasting blood sugar under 100. Now, all of these can be aided by healthy lifestyle. And I want to highlight for us that in this country, cardiovascular health is poorer in young women overall, particularly during pregnancy. When you compare comparably aged pregnant and non-pregnant women, the pregnant women have lower cardiovascular health, which likely explains both their complications of pregnancy and the transmission of risk to their offspring. Cardio health is particularly poor in non-Hispanic, Black, and Mexican women. And what we see, the woman who develops blood pressure elevation during pregnancy has an increased subsequent risk of coronary disease and heart failure. And something that we've not addressed enough in our conversation is the issue of rurality, because there are increased disparities with rurality. Maternal mortality is higher in rural rates, and I'll come back to that in a few moments. Next. So that the preventive interventions that we advocate have to reflect the intersectionality. Let me show you some of the problems. We see as an advance that more women met physical activity goals in 2018 than they did 20 years ago. But that's only 20% of women who meet the physical activity goals. 80% do not. And nearly half of women in our country fail to meet their aerobic activity and muscle strengthening guidelines. And actually, there are disparities in meeting the guidelines. Guidelines are met better by white women, less by non-Hispanic Black women, and intermediate by Hispanic women. And what we're seeing is a great deal of intersectionality. There's an association of income with meeting physical activity guidelines, and that's consistent with the adherence that we see related to the social determinants of health. Next. I've told you what the background is. Well, what are the knowledge gaps and what are the research needs? First, as I've suggested, we have to develop and deploy risk calculators that incorporate sex-specific and sex-predominant risk factors. We need cross-disciplinary research, in the social determinants of health, because that's necessary to design interventions to address these determinants. We have to define and implement cross-disciplinary interventions. And that means we go outside of the medical community. We go into communities, health systems, business, urban developers, economic researchers. And then we have to implement those risk interventions that embrace this intersectionality and have cultural sensitivities. But importantly, we have to adopt and implement a lifetime approach to risk management. This doesn't start at age 35 or 40. It starts early on and goes throughout the lifetime. Next. Let's now change focus and address the awareness of cardiovascular disease in women. Because since 2004, there have been educational and advocacy campaigns designed to increase awareness. This was the National Heart, Lung, and Blood Institute's Heart Truth campaign and the American Heart Association's Go Red campaign. And what they did was they increased the awareness of women from 30% to 56%. Certainly an increase, but still almost half of the women had no awareness. And then when we revisited this in 2019, there was almost a 75% drop in the awareness that cardiovascular disease was the leading cause of death, and that lessened awareness was most prominent in the women at risk, younger women and Hispanic and non-Hispanic Black women. And the same thing in 2019, fewer women recognized common heart attack warning signs, with the recognition least among younger women. And that may be a major contributor to the fact that the younger women, when they have these symptoms, do not present promptly to the emergency room. And this is a major educational need that we must impart to the community. Next. But it's not just the public, and it's not just our patients. Education of health professionals is requisite to improve awareness of the risk factors in women and the course of cardiovascular disease in women. In one study, 70% of postgraduate medical trainees reported that they received no or minimal sex-based medical concepts during any of their medical training. And in a study, 22% of primary care physicians and almost half of the cardiologists were the only ones who felt well prepared to assess cardiovascular risk in women. We must address the education of our physician workforce, and we need collaboration between the OBGYN clinicians and the cardiologists, because for many ostensibly healthy women, the OBGYNs are their primary care physicians. OBGYNs are in the preventive mode. They recommend mammograms and pap smears, but they're not addressing the major health problem of women, and that is cardiovascular risk. And going to the other way, the OBGYN clinicians must share with the cardiology and internal medicine community the awareness of pregnancy-related cardiovascular risk, because that is an ongoing problem. Next. So as I've suggested to you, these awareness data show that we've lost a decade of progress, but there may be some promise, because early on we did not have social media channels, and now we have to target our younger audiences through social media channels, and we will need the younger people among us to show us how we can do this best. And interestingly, the American Heart Association's Go Red registry is a wonderful source, because it's designed to achieve awareness, engagement, and scientific contributions by a real-world partnership between women and the researchers. And the Research Goes Red database is open to clinical scientists worldwide. Next. So what about the knowledge gaps and the research needs in terms of awareness, which is a very important sector? As I've said, we have to implement approaches to lessen the decline in awareness of women that cardiovascular disease is their leading cause of mortality. But it must be culturally sensitive for specific racial and ethnic groups. We have to educate healthcare professionals in their undergraduate and postgraduate training about the intrinsic and extrinsic age-specific risk factors, so that they can recognize and treat women who are at risk for cardiovascular disease. Next. Now, a critical area of importance, and that is the access to and delivery of equitable health care. Let me give you some background information. And in doing the research for this presentation, I found a number of shocking facts. Fact is, access to affordable insurance coverage and out-of-pocket costs affect healthcare access and use for women. More than a fourth of women in this country spend $2,000 or more in direct cash on medical costs every year. And more than a third report that they skip medical care due to cost. The Patient Protection and Affordable Care Act, otherwise known as Obamacare, gave the largest insurance coverage gain for women aged 19 to 64 years. And the percentage of uninsured women was a third lower in 2018 than it was in 1984. But look at the percentage. It's still 10% of women who are uninsured. And interestingly, if we examine who benefited most, the medical expansion in the ACA had a beneficial effect on healthcare coverage and use, particularly in low-income women of reproductive age. And what we're seeing now is that, remember, Medicaid is covered on a state basis. And for example, in my state of Georgia, we have worked with our legislature and we've been very successful. Previously, women were covered during pregnancy and until their 6-week postpartum examination. Now in the state of Georgia, women are covered for 12 months, which gives us the opportunity to have a substantial effect on maternal mortality. Next. Let's go back to this issue of rurality that I raised. Women in rural America have a greater cardiovascular risk compared with women in urban settings, and it's less access and less healthcare system delivery. And what we're seeing is that the life expectancy gap between rural and urban areas is increasing. It used to be half a year, then 2 years. Now it's more than 2 years. So the rural group are tremendously disadvantaged. It's hospital and outpatient facility care, it's clinician supply, it's insurance coverage, it's public health infrastructure, which is lesser in rural compared with urban areas. And we saw this in the COVID-19 pandemic, and we saw that pandemic effect on the under-resourced rural healthcare systems. Next. Additionally, a higher percent of women compared with men delay medical, prescription, and dental care simply because of cost. And as well we know, delaying care delays diagnosis. It delays the delivery of optimal preventive care. And if you delay care, when you come to illness, you're going to be sicker. And therefore, there are more adverse outcomes after an acute cardiovascular event. And what we're seeing is that despite the fact that women have a lower prevalence of myocardial infarction, of heart attack than men, disparities persist in treatment, in care, and in mortality. Women have higher mortality after all coronary interventions and after coronary bypass surgery. Next. Now, this is a little bit technical, but it is addressed both to healthcare professionals and otherwise. Women have non-obstructive coronary artery disease more frequently than men, about 3 times more. Mortality is higher in women, especially at younger ages. And interestingly, with an acute coronary syndrome, women under age 65 have lower rates of getting to the cath lab in the critical time under 90 minutes because time is muscle. There's no treatment gap for women older than age 65. And we have to have our emergency room colleagues realize that it's not just the old ladies who have heart attacks, it's the young women, and they have to get to the cardiac catheterization laboratory promptly. And then there is unconscious bias, if you will. This is a study that presented the clinical history and gave pictures, women versus men, Black patients versus white patients. And with the same clinical history, physician recommendations with chest pain to go to the cardiac cath lab were less for women and for Black patients. A very important disparity. Next. Now, it's not just coronary disease, it's other diseases as well. The American Heart Association has a Get With the Guidelines heart failure registry. And even though there were no major differences between women and men, there was something really quite important. Women were more likely to be treated in hospitals that had a higher proportion of Medicare, Medicaid, dual eligibility. And those are the hospitals that generally, because of their resources and the population they serve, have poor outcomes. Women who had a low pumping function of their heart were less likely to receive a defibrillator, whether they refused more or whether they were not recommended, not certain. Now, we're seeing a great deal of information about mechanically assisted circulatory support. And now either the devices have been tailored, and some of them are smaller and therefore more appropriate for women, but women who receive mechanically assisted circulatory support still have greater mortality than do men. What about stroke? Again, the Heart Associations get with the guidelines stroke registry. Women who have a stroke are less likely to be transported to the hospital by emergency care medical services, less likely to receive brain imaging within 25 minutes, which is the recommendation, and less likely to receive lytic, clot-dissolving therapy within 2 hours. Should we then be surprised that women are more likely to die within 30 days of their hospitalization for a stroke? Next. So what are the knowledge gaps and the research needs about access to care? What can we do to assist women to overcome the medical cost barriers to delaying healthcare and prescription drugs? We need research. We need to know what the specific barriers are if we are to be effective in changing healthcare policy. How can we best improve the knowledge gap, education, and awareness of healthcare professionals and about female-specific and female-predominant risk factors? And we have to explore the role of the COVID-19 pandemic, which had a particularly adverse effect on women because of their economic, social, and family demands. How did it affect their total health, their cardiovascular health? And we will just be seeing this in the years to come. And then how best to adapt technology so that women get more efficient care when they come to hospitals. Their time is very, very precious due to their multiple care demands. Next. Now, this is something that I have a great deal of interest in, and that's the interest of standard nomenclature. The problem is that the research studies have small numbers of women and even smaller numbers of women for underrepresented groups. So we're probably going to have to group studies to get data. And we must have standard nomenclature of illnesses, of problems, et cetera, because if we have that, there's a greater likelihood that artificial intelligence and machine learning can accelerate our understanding of the factors that regulate cardiovascular risk in women. But the baseline need for the AI to come in and do its thing is standard nomenclature. Then what we have to do is expand the use of social determinants of health indicators in the electronic health records so that we can understand how external factors, environment, social determinants of health modify risk over a lifetime. I don't know how many of you who have had the pleasure of a visit from the Joint Commission to accredit your hospital, but the Joint Commission now requires that the electronic medical record include the social determinants of health. But the devil is going to be in the details. Do they just have to be in the record where we can extract them, or should there be a particular area in the electronic medical record that specifically addresses social determinants of health? We'll see how that plays out. Then another feature is that the traditional approach that we've used to research is to go back and capture longitudinal data trends, but we're advocating changes now. And what we have to have is a look-forward mechanism so that we can sample the trends from large data resources that we are trying to implement in addressing awareness to see if we're going in the right direction. Next. Finally, I have a few calls to action for all of us. Call to action first, culturally sensitive with appropriate translation awareness campaigns that identify cardiovascular disease as a major health threat for women and that emphasize the benefits of prevention. Plus, almost 80 or 90% of cardiovascular disease is preventable or at least delayable. And the benefits of lifetime cardiovascular health optimization, the old Life's Simple 7 and the new Life's Essential 8. We need interdisciplinary collaboration among the cardiology community, the vascularologists, the primary care, the OBGYN, so that we improve the recognition of women's lifelong cardiovascular risk and have holistic risk-reducing strategies. We have to educate about the risk factors specific to or predominant in women, and we need risk calculators that give us quantitative measures of risk for the life course. And these may be different in childhood, in adolescence, in the reproductive years, and in other primary care visits into elderly age. Next. Advocacy for basic translational, clinical, population, and implementation research on cardiovascular disease and stroke prevention for women of all ages, but with a focus on the under-resourced population. We have to make everyone realize that there are high reward opportunities if we can achieve lifelong improvement in cardiovascular health. And in the research arena, we have to be sure that animal studies include female animals. That was not requisite until the Research for All Act in 2015. And ensure that in basic science, the tissues and cells, we know whether they come from female or male animals. In the past, basic science researchers may have been using tissues and cells from male animals to study female problems. Clearly, that is likely inappropriate. And then in the clinical trials, we have to augment the participation of diverse populations of women. We're doing moderately well with women of middle age, but we need increased participation of younger and of elderly women. Next. And we have to engage communities to optimize cardiovascular health across the life course. We need to go back to school-based programs where the children bring information home that will help patients and empower their families. We have to meet the underrepresented groups where they are in the communities. We have to partner with communities of faith and barbershop and other groups. I don't know how many of you are aware of the barbershop study. It's one of the great community studies. And what was done is that in the barbershops that were frequented by Black men, they put a pharmacist. And the pharmacist discussed blood pressure medicines, blood pressure measurement. And the outcome was striking: a lowering of blood pressure and increased adherence to blood pressure medications. Why aren't we doing this for women in the nail salons? Why aren't we doing this for women in the hairdressers? This is a tremendous community opportunity. We have to engage departments and schools of public health to integrate public health and primary care, and then advocate for public policy and legislative interventions that focus on social determinants of health, access to healthy foods, safe spaces for physical activity, clean indoor and outdoor air, and access to high-quality care for prevention and treatment. Next. And finally, we need to put in surveillance systems to see where we go on the cardiovascular risk factors so that we can assess the progress and provide key feedback to the key stakeholders, and there are many. And we've not adequately leveraged innovative digital technologies to capture the metrics for prevention, for outcome, and for care delivery. And again, let me cite the AHA's Research Go Red database, which is uniquely positioned to track life course events. Let me summarize. Next slide, please. Reducing the risks and burden of cardiovascular disease in women takes a community. We have to raise awareness. We have to optimize prevention and clinical care. We have to support research. We have to engage communities. We have to advocate. And then we have to monitor our progress. And I thank you very much for your attention.
Well, wow. I think we all need to take a deep breath. We have about 55 individuals with us in addition to our speakers. And I'd ask Dr. Wenger, if you could stay on camera, and I'll invite Dr. Ellen Gritz to also join us by unmuting and putting her video. So I am going to check. I ask the audience to please post your questions, and I will do my best to have as many of your responses included. So as you're doing that, I certainly want to thank, first of all, Dr. Wenger, okay, for your insights. It's really a whirlwind over the decades that you have not only pioneered, but persisted in moving the field forward. I want to thank Dr. Gritz for the honor of having two. Now we have not just one, but two Alma de Morani recipients. And open, I see there are some questions that are coming in. I see no questions yet. And okay, I do see one. And I'm going to start with a question, but I'm going to reserve the right also to pose a question because you have given us such a whirlwind review. There's some key points that we'd like to discuss. So the first question is, in the current climate where women's health seems to take a back seat, how do we refocus the discussion and come back to putting women's health at the front?
What we must remember is that women's health really includes the health of the family because women make the major health and medical care determinations. The health of the family determines the health of the community. The health of the community determines the health of the nation. So this is a matter of our public health. And this then becomes a public health problem and one that is addressed, as I suggested to you, by multiple stakeholders in the public health.
Thank you. And I want to just note that that question was posed by Dr. Teresa Rohr-Kirschgraber, who has been a past president of Alma and obviously fully engaged in these discussions. I see questions are coming in, so I'm thrilled. This is a question for Dr. Christy Huddleston. Dr. Wenger, thank you for your wonderful presentation, she states. How did you get interested in this area of medicine? And if I could add to Dr. Huddleston's question, how do we motivate our current trainees into this field and then support some of the things we've learned? You talked a lot about social determinants of health. The structural inequities have come into focus, certainly around COVID and structural racism, and you mentioned implicit bias. How do we take this to the next level with the current diverse health professional field that we have?
Okay, let me sort of try to answer the serial questions that
I'm
you
sorry.
Okay, I should have had a pencil and paper, but let's see if my brain will function. I was always interested in science, but I'm very much of a people person. And medicine really seemed the ideal area to do science and to help people. And during my years at the Harvard Medical School, I had some fantastic mentors in cardiology. Sadly, I had no women mentors. There were no women in the years ahead of me. And what they did was to teach me how exciting the emerging field of cardiovascular medicine was, how we were beginning to take data derived in the laboratory and translate it into clinical care. So this was stunning. New advances in diagnosis and in therapy were literally coming out every year. And it was like practicing frontier medicine. There was something new to learn all the time. And all clinicians know that we're engaged in lifelong learning to provide optimal care to our patients. But we now have to translate that into lifelong learning for our patients. We're responsible for doing community education so that when patients come to us, they have the background of cardiovascular education and information in their community, and then we can provide to them the cardiovascular education about their particular health problem. But we discussed this. I'm at a meeting discussing sex and gender issues in cardiovascular health. And one of the questions that was raised is, what is the relationship with patients? And how do you get patients involved in their care? You know, we throw around some terms: patient-centric care, precision medicine, etc. One of the things I've worked with my trainees is to ask a patient, what is it that you anticipate to acquire from this visit with me? And often you'll be looked at in disbelief because it's an unusual question. So you may have to suggest, is it that you want to feel better? Is it that you want to improve your function? Do you need more information about medicines? Do you need more information about tests? Do you need financial aid, etc.? But if you give them a spectrum, it is delightful how patients will begin to respond and tell you what matters to them most at the moment. And if you address what matters to the patient most, then you can follow it up with what should matter to the patient in terms of the management of the disease, in terms of prevention, in terms of adherence to lifestyle recommendations, etc. And we have to learn not to overload patients with information at a visit, because we have to be selective in what we recommend. And if the patient's main concern is to relieve symptoms, then we start with the medicines that relieve symptoms and then say, this is what will relieve your symptoms. But I'm sure that you want to live longer, so let's do this, this, and this as well. But let the patient, the informed patient, guide the clinical discussion at the visit.
Thank you. Thank you. I'm looking at a series of questions and want to see, and a number of them speak to the thoughts about expanding partnerships with OBGYN. And we did have someone pose the question in terms of the increased risk for maternal mortality in Black women. Can you speak to those expanding partnerships with respect to understanding cardiovascular risk and that intersectionality issue?
Well, there is a joint statement from the American College of OBGYN and the American Heart Association that goes back a couple of years, and I think I was one of the authors on the statement. But what you must realize is that for ostensibly healthy women, the OBGYN is their primary care physician,
Sure.
very, very often. But the OBGYNs are in the preventive mode. They're prescribing mammograms, they're prescribing pap smears, but they're not yet addressing the major cause of mortality in the women they serve, and that is their cardiovascular risk. So at least be prepared to do a risk assessment and to realize that the woman who has had a complication of pregnancy is at increased cardiovascular risk. Let me give you an example. In our Women's Heart Center at Emory, we have a cardiologist in the 6-week visit appointment post preeclampsia. So there's a post preeclampsia clinic. We have a cardiologist there who meets the women where they are, who discusses the fact that because they've had the preeclampsia, looks at their risk profile at 6 weeks, identifies for them interventions that are needed, identifies for them that they are at increased cardiovascular risk. Doesn't mean they're going to have problems right away, but they need to lose that baby weight. They should not restart their smoking, which often they've stopped during a pregnancy, that they need to exercise. It's just going through all of the lifestyle interventions, and that they need to follow up if there are any borderline or abnormal values over the next 3 to 6 months, and then just say, if any problems arise, remember we've had this discussion and I'm delighted to see you. So it doesn't entail a separate appointment. We're meeting the women where they are and sharing with them that we are concerned for their cardiovascular health.
Thank you. I see we're almost out of time, but want to emphasize that you're speaking about national efforts, although, as you said, the financing of care is complicated. We have not gotten to that question for you, but that the continuum of care and how we educate our primary care and our specialists and how we break down the silos of those teams may be increasingly important. So, but I have a ton of questions here, which we will not get to. I do apologize to our folks, but thank you for pointing out a number of things and the social determinants and the structural inequities that contribute, the external factors, as well as what can be done in the now. And I loved your thoughts about sampling trends so that we can act more quickly in attending to people's needs, and of course, community engagement. So now we we really thank you for your inspiring remarks, and I know that folks will feel that they have identified a leader that will continue to influence future leaders. So on behalf of the Women in Medicine Legacy Foundation, I am pleased to present you with the 2023 Alma Morani Renaissance Woman Award, an honor that I don't have to say, but is so well deserved over decades of innovation, pioneering, and really understanding the needs of women. We are, after all, 50% of the population. I also want to thank Dr. Kurth and the entire team at NIAM, as well as the Women in Medicine Legacy Foundation Board of Directors for their assistance in hosting this year's award presentation virtually. And thank all of you for joining us today in recognizing the career and accomplishments of our 2023 awardee, Dr. Nanette Wenger. And I know you can't hear all the claps, but I'm going to begin to say thank you so much. As a final note, members of the 1849 Society should reconnect to Zoom for our post-event discussion, which is a smaller, more intimate discussion of this, but please feel free to join us. We would like to continue the conversation, and we will be posting a number of these things on our website and Women in Medicine Legacy Foundation. If we could have that final slide when you can see the website. Thank you so much, and thank you for joining us. Thank you, Dr. Wenger and Dr. Gritz.
Thank you.